So for those of you who haven't met, my name is Kevin O'Connor. My daughter, Caitlin, had a hemispherectomy 9 years ago, and she's doing really well. But this is near and dear to me because she's 22, transitioning to adult care, and sometimes it's a bumpy road. Everyone means well, but sometimes the transition's a little challenging. Today I'm have the privilege to introduce Dr. William Welch, Director of the Pediatric Epilepsy Surgery Program and Epilepsy and Neurostimulation Program at UPMC Children's Hospital of Pittsburgh, certified in neurology and epilepsy with a special qualification in child neurology. The clinical research interests include the treatment of epilepsy with vagus nerve stimulation, responsive stimulation, and deep brain stimulation. So it's my privilege to introduce Dr. Welch.
Hi, everybody. Thanks for coming. I'm Will. We're going to get started here. So we'll chat today about transitioning to adult neurological care from pediatric neurological care. And we'll go through a few things. So define the terms a little bit. Kind of what are we talking about? What are the problems that we're facing? What are the barriers and pitfalls to be mindful of? Some of the common principles, which are going to sound familiar to a lot of you, I think, and then some guidance specifically for epilepsy surgery transition, because there are some obviously unique features of transitioning in that context compared to other neurological conditions. So what do we mean when we say healthcare transition? Obviously we're talking about moving to kind of a new model of care, and it's really a child and a family-centered model to an adult and patient-centered model. And so this can be, importantly, with or without transferring to a new clinician. So this may mean transferring to a new practice, a new adult center, with a lot of unfamiliar faces. But you can also implement this model even as your child with epilepsy is entering adulthood, but maybe doesn't have to transition out of the pediatric program yet. So it's important to keep in mind as well. Why does this matter? Why am I talking to you about it today? It's an essential component of a comprehensive epilepsy care, continuity of care for any chronic disease, but particularly in epilepsy as a potential lifelong disease. It's important for safety, so these handoffs are really important. Having information in the places and in the hands that it needs to be in to keep young adults safe. It's a complex system, as all of you are very aware, and there's not a one-size-fits-all approach, so individualizing care depending on the complexity of care and the complexity of the system. And it's important for maintaining trust with the medical system and specific clinicians, right? So moving from hopefully one trusting relationship to another. This is an essential component of self-advocacy for patients, for young adults, and diversity and inclusion. So children with history of epilepsy surgery, or even patients who have epilepsy have not yet undergone surgery, are an important part of the educational system. It's important to find them meaningful employment to ensure that they're able to pursue healthy relationships and have independent or at least interdependent living. What's the problem? Why is this so hard? It's an anxiety-inducing, huge jump for everybody involved, for children and young adults, for their families, and oftentimes for the pediatric neurologist and the pediatric team who's been taking care of kids for such a long time, taking care of a patient for a really long time, and they don't want things to be missed. They don't want someone else to drop the ball, right? This process can have gaps. Things can get missed. Appointments that are made, things don't get followed through on. The person that you're hoping will be there on the other side to pick up the ball may not be able to do that. And it's a long longitudinal transition. So it's this long bridge that we're trying to go across. And all the different areas in which we need good, solid, comprehensive care oftentimes seem siloed into these different divisions, and nothing is put together the way it should be sometimes. So this is what we worry about, right? Is that along the bridge, everything collapses, right? This is what we're trying to avoid. And this is just showing, all these different areas, not just the medical condition itself, but legal issues, financial issues, community involvement, employment, all these things have their own communities and their own specialists who know what they're doing, but it's getting them all to talk together and see your patient, your children holistically. In addition to the system being tricky, epilepsy itself interferes with this process. Right? Just the disease itself interferes with the typical maturation of adolescence into adulthood. And so when we think about these different domains that influence maturation into adulthood, we think of autonomy, body image, peer group identity, and identity, self-identity, right? And so these are all questions that patients with epilepsy, families of patients with epilepsy ask themselves all the time. For autonomy, simple things like bathing, swimming, driving, eventually things like alcohol and drugs. Young adults who say, I can't live the life I want to live. I can't do the things I want to do. I can't do the things that my friends are doing. For body image, medication side effects, injury, neurologic deficits, these all influence this idea there's something wrong with me. There's something that's affecting my body image. This is all inhibiting the ability to typically mature into adulthood. Peer group identity, things like involvement with sports, avoiding other kinds of activities, dating, the idea that no one else that I know has this problem. I'm the only one who has this problem. And then identity. How am I going to do some of the basic things, the existential questions, right? How am I going to provide myself? How am I going to get married? Am I going to die from SUDEP? Who am I? And what kind of adult am I going to be? All these things are impacted by the disease, sometimes the treatments of the disease. And so this is another barrier. Competing perspectives, right? So teens and young adults have different worries than the parents and caregivers who've been taking care of them for a long time. Some of the things that were mentioned in that last slide, right? So the teen is worried about, in the context of transition, finding a new trusting provider, maintaining self-care, dealing with all the new responsibilities that are being asked of them or expected of them, or things that they hope will be expected of them. And what other long-term goals are going to be, how are they going to be included holistically. Whereas parents during this period are much more worried about, or surveys would suggest that they're much more worried about being undervalued in that process, being ignored in that process, kind of being locked out of discussions, not being involved. And even in the best scenarios, the role is changing no matter what. And that can be disconcerting in and of itself. And then, of course, ultimately, safety, doing what's best for the child, young adult, as they go along this journey. I think it's important to note that when it comes time to talk about transition in clinic, oftentimes we're in a position where the adolescent with epilepsy has not been involved in the discussions at all for years. And so there's a lot of catch-up, oftentimes, to find out where is that patient on the spectrum of sort of preparedness for transition. Where are they? What's their understanding of the disease? And so part of these principles are starting this conversation early and hopefully avoiding that concern. Comfort, it's also a big barrier, right? Leaving a hopefully trusting relationship with your pediatric specialist, neurologist, neurosurgeon, rehab specialist, and finding someone else who you can trust just as much. Difference in attitudes between pediatric and adult specialists. There's no question that there is some difference in demeanor between most pediatric neurologists and other subspecialists and our adult counterparts. Fewer high fives in the adult practice. Doesn't have to be that way, but I think it probably is. And then some real and some perceived lack of comfort with some of the other comorbidities that go along with epilepsy and epilepsy surgery on the adult side. Questions of, kids with autism spectrum disorder or other developmental delays, aggression, or sometimes overaffection. How will that be received? How will that be dealt with on the adult side? All of us in pediatric neurology have spent some time in the adult neurology and adult epilepsy clinics, and I think, again, some of that is perceived. I think that they are well equipped and excellent to deal with these comorbidities, but there is a difference. They don't see the same type of patients day in and day out, and the vibes are different, so to speak, right? So as this picture shows, I think every waiting room could use a few more choo-choo trains and aquariums for comfort. I think we'd all be better off, but it's a different feel on the adult side. And we can't just blame the adult providers either, right? So we know that we're not always, on the pediatric side, always well equipped to deal with this transition. So the group from Pittsburgh, Dr. Kirkpatrick, Dr. Kasimirski in pulmonology, and several other folks looked at this and found that we are not as prepared as we think we are to transition young adults to adult neurology. So less than 50% of us were really comfortable with our knowledge of epilepsy transition or neurology transition, particularly when it comes to legal and financial questions. And less than 50% of us discuss this transition annually, which we should do. Right, so it's on all of us to do a better job with transition here. So those are the problems, the different perspectives. What are the goals? What are we trying to achieve? And like I mentioned, this longitudinal process across the beautiful Pittsburgh Bridge that you see there is what we're going for. So initial discovery of the process, tracking progress, preparing, planning, replanning, and then finally transferring and completing care, hopefully smoothly. And then moving from those silos of specialization to sort of more interconnected model where these things all work together as best we can. This is sort of a busy way to illustrate kind of how we think of things. So moving from early stages of transition, starting in early adolescence through early adulthood, with the changing roles of each person, the pediatric provider, the caretakers, the patient themselves, and the adult provider. But really the goal being that eventually the young adult becomes the CEO of their own healthcare, the supervisor of their own healthcare. And if all goes well, these roles can kind of smoothly change over time. And we'll go into some of those details here in a bit. So these are the common principles of transition that many of you are probably familiar with. And many of us use the Child Neurology Foundation these are their principles that they've published and done a lot of work on. We don't need to review necessarily all of these. This is really directed more at us as child neurologists, but these are the things that we should be thinking of, families should be thinking of throughout this process, starting around age 12 or 13. And each one has a specific purpose. And again, if all goes according to plan, this sets you up for as smooth a transition as possible to the adult side. So we'll just kind of go through these with some examples. Again, all this is from the Child Neurology Foundation, and so these forms are actually on their website, and I think are really fantastic. I have had a few families who just print these out and bring them to clinic, but you can make your own. There are other versions of this that can be found. But we'll start with the expectation of transition, which really, as I mentioned, should be started around age 13 or by the 13th birthday. And most practices are going to have some kind of policy in place about when a patient must transition, but there are not policies in place most often for when this process needs to start and how exactly it happens. When you're starting this, again, around hopefully age 12, 13, 14. This is when you want to start to build your team or realize who your team is going to be. Ask about the transition policy, those things that are sort of written in stone, so to speak, and then figure out what kind of team you're going to need to put in place over the next several years. Coming prepared with these readiness assessments and the things that we'll show you can be really helpful. Medical summary template, lots of questions, and making sure that the physician or APP or anyone who's taking care of your young adult is talking directly to them. Speaking as a pediatric epileptologist, I encounter situations where a young adult really wants to be spoken to directly. They want to be in charge, and times when they are really disengaged and it's really challenging. And on the other side, I see families who are really ready for their young adult to take charge, answer questions, and be involved, and other times when they're not quite prepared to do that, not quite ready to do that, because they're so used to sort of being in that caretaker role, managing everything and keeping everything on track, and are excellent at it. The yearly self-management assessment, that thing that I said less than half of us actually do, there are really simple and easy forms for assessing this as well, and can and probably should be completed by both the child and the caretakers to sort of see, to make sure everything is lining up, make sure these perspectives are aligned, and really identify the goals and opportunities for education, of which there are always going to be some, and creating goals as you go. And some of these goals will seem very small, some will seem easy, and some will seem very difficult or insurmountable. But really, starting small makes sense. And this is not necessarily small for everybody, but starting with the goal of, I take my medicines without someone reminding me, right? Most of the patients that I see would mark, they still need to learn this if they're answering honestly. But then not just sort of checking the box and moving on, but really coming up with ways to operationalize those goals. So again, keeping it simple, but make it clear. So we're going to buy a pill tray, we're going to learn to fill the tray, take the medication with supervision, moving on from there to managing medications independently, and moving to the, yes, I know this, let's move on to another goal, something else to take on for the next visit, right? Or a couple more things to take on for the next visit. This is just a long, kind of busy way of listing out the different things that can be discussed during an annual visit. I think it's important to recognize that doing all of this in a 20-minute or 30-minute follow-up visit is impossible. But this can be done over multiple visits. This can be done, some of these things can be addressed with your neurologist or neurosurgeon, some with the rehab specialist, some with an endocrinologist or a primary care provider. But making sure that at some point, again, keep being organized and keeping a checklist of things that have been discussed or haven't been discussed yet is really important. And keeping in mind also that a lot of these things are going to be discussed without caregivers in the room, because it's important to talk to young adults alone, which most people are really comfortable with, but every once in a while, depending on the developmental stage and comfort level of the families, that can be a difficult discussion. But all this is to really address all the concerns, all the domains of wellness that we're trying to, again, communicating transition smoothly. Expectations for legal competency is another big issue. I should have said earlier, but most of these slides could handle a whole hour presentation on their own. So I don't mean to gloss over things too quickly, but these are all really, in and of themselves, complex topics. Some of them have been discussed at other sessions at this conference. But finding resources and thinking about legal competency early is really important. Anything on the spectrum from independence to legal guardianship and planning assessments with a team approach if necessary, neuropsychology, neurology, rehab, all the different subspecialties that you're involved with, planning assessments if this is unclear, engaging a social work team, hopefully through a multidisciplinary clinic is really helpful, and engaging legal resources is also really helpful. So in Pittsburgh, we have the Health Law Clinic. We refer many families to discuss the implications of these decisions. And it's a great resource. I suspect this exists in a lot of places, but it's not going to exist everywhere. So there'll be a big page of resources at the end, PISA being a major one of those, but there are a lot of resources to find help for these really complex questions. This is a little bit redundant, but an annual review of an overall plan of care is important. Should be a very collaborative process between young adults and their caregivers. And this is addressing not just different health needs, so not checking down the list of subspecialists that you're going to be visiting and the medicines and things like that, but overall goals for education, employment, housing, finances, kind of these big picture things. What are the issues of concern? What are the actionable items, moving over the years? And again, starting early so that these things can be thought of well in advance before there's an emergency, so to speak. Identifying an adult provider, so collaborative effort to find a good therapeutic relationship. There is almost always more than one good option, but finding the right fit is important, and we all understand that not every neurologist is the right fit for that specific patient and family, and that's totally understandable. Things that can facilitate this are a good, comprehensive, but efficient transfer letter and note, prior assessments, transition assessments, plans of care, comprehensive medical summary, and then any necessary legal documents. These go in the big binder that people carry around, which I should also mention as a slight aside. The binder is great. The binder is awesome. A thumb drive is a great option, and I saw several reviews that talked about this specifically because it's small and portable and efficient. But nothing is quite as great as just seeing things on paper and not having to worry about whether or not that file is going to open up on your office computer, or if the thumb drive is formatted the right way. So hard copies of all these documents are actually really useful, and I know they're much heavier than just a thumb drive, but that's just a slight aside. For epilepsy surgery transition specifically, so a lot of this is we've been talking about is general neurology transition, which of course applies to epilepsy, but like you mentioned early, the epilepsy surgery transition is unique. There are so many subspecialists involved, other concerns involved, and it depends on what stage of that journey that you're on. The stage really dictates the specifics of that transition and how it's going to go. For patients who have epilepsy and still have not received epilepsy surgery, I think when epilepsy surgery is planned, it's unlikely that you're going to be transitioned abruptly to an adult provider, but people who are still, maybe haven't decided about epilepsy surgery, or for whatever reason haven't had surgery yet, is a different scenario than if you had epilepsy surgery in the last year or so, which is much different than if you had epilepsy surgery a decade ago. The outcome is going to influence things. Is the young adult seizure free, or are there ongoing seizures? That's really going to massively change the urgency with which the transition needs to go smoothly, and the different types of providers you're going to be seeing. And then the effects of the epilepsy surgery, cognitive or behavioral concerns after surgery, deficits from surgery, device management. Do you need to be plugged in with just an epilepsy clinic, or do you need to see someone with specialization in RNS or DBS? These are important things to consider, adding just another layer of complication, unfortunately. As I've mentioned a couple times, a multidisciplinary approach is best, right? And so not everyone is going to need to transition to someone new in each one of these fields, and there are some that are not listed here that would need to be included. but for the majority of epilepsy surgery patients, following at a center, being established with a group with an experienced epileptologist, neurosurgeon, rehabilitation medicine, PM&R, neuropsychology, all these things are really important. And then social work can have a lot of input on how to navigate the adult world. Behavioral health may or may not be useful in some situations, depending on deficits. Things like ophthalmology, other subspecialists can be key. So again, not to hit home this point too hard, but a multidisciplinary approach really is essential. I'm seizure-free. Do I need to transition to an adult epilepsy team? Yes, when the time comes, I think it's really important. And again, some of this depends on, like the prior slide detailed, what the outcome is, what the other deficits may be. But are you still on medications? Because those still need to be managed by someone on the adult side. Follow-up imaging is very likely going to be indicated at some interval, and so being established with a team that can coordinate that. Having all those assessments, all that summary, the history, the treatment details, what happened and when in that adult system, so to speak, is really key. And it's kind of one of these logistical things that that sometimes are overlooked. Most level 4 centers are going to have, pediatric level 4 centers are going to have an adult counterpart, like we have in Pittsburgh. The system between the adult side and the pediatric side don't speak to each other. So they can't see what happened 5 years ago or a year ago on the pediatric side. And so having all of that, even if it's just an introductory visit without much to do, but all that information gets put in the system so that if an emergency arises, if something comes up, that's all there. And there's someone with familiarity who can become familiar quickly in case seizures return or there's some other emergency that needs to be addressed.
I have a quick question on that. I think many of us have encountered that these systems that from pediatric to adult don't speak even within the same hospital. For example, we had to send huge files between the two. Is that a legal reason in many states, or is that simply how the hospitals are designed and systems?
It's a systems problem, I think, most commonly. It's just different groups using different electronic medical records, and the way these Byzantine systems were built over time, they're siloed, really. And so, for instance, in our system, which is unique and may not be the case anywhere else, I can access the records on the adult side really pretty quickly and efficiently, but the reverse is not true. And so some variation of that is probably pretty common. Whether you can see EEG reports, but maybe not see neuroimaging, these things are all different sort of systems within systems that add to the complexity. It kind of goes back to really keeping those records in one place and guarding them, and when possible, getting them into the adult hands to be uploaded is really important. And that's not all on families. That's on us too, to make sure that we're communicating, sending those records over when possible. Let's see. Kind of just discuss our center's approach here. So we have in our epilepsy division several different clinics, and we all work closely together. But we have epilepsy surgery clinic. We have ketogenic diet clinic. We have the so-called uncomplicated epilepsy clinic, tuberous sclerosis clinic, RNS and DBS clinic, as well as others, right? So all these sort of clinics that are under the epilepsy umbrella. And we have different faculty who attend to these clinics and specialize in these different areas, and then APPs who, a couple of whom have a specialized experience. So a couple APPs PAs who have a lot of experience in these clinics and are really helpful. And so what we designed in Pittsburgh is a way for all these patients to be evaluated to facilitate transition to the adult side. And so Dr. Patrick, who was one of the folks who did the survey I mentioned earlier, started this clinic with one of our PAs, Kirsten Resnick, and is a really effective way, either in person or virtually, to set up a new patient visit, so a 40-minute or an hour visit to, picture disappeared, but that's okay, to discuss with an epileptologist and an APP, and have nursing support for the clinic for all the things that have to happen after the visit. It's a supplement to ongoing care, so it's not moving everybody away from these specialty clinics into a transition clinic, but sort of bouncing back and forth, right? So they will return to their sort of standard care, their regular care in their subspecialty clinic, but will have access and input from the transition clinic. And this is really dedicated to address all these things that we were discussing in prior slides. They're really dedicated to making sure that young adults, teenagers are ready and have access and know all the sort of hoops to jump through to get everything established on the adult side. And have access to resources, which are sort of shifting targets. So knowing who the person to call at the medical law clinic if there's a question, knowing who the best person to touch base with social work on the adult side, things like that, things that we aren't always on top of necessarily in the subspecialty clinic or have time to address in that visit. These are all the different resources that are available, and there are certainly others. I used some amount of input from almost all these, putting this together. So the Child Neurology Foundation really has established those principles that we try to follow. Got Transitions is great for sample documents and other supplementary information. Your local epilepsy association is an invaluable resource for local resources. And then conference, just like this one. AES, Child Neurology Society. This is a relatively hot topic in epilepsy and lacks a lot of consensus. So going to meetings, meeting people who are going through transition or anticipating going through transition or have been through it is really important. So these are all ways to get more information. Any questions about any of that? Yeah.